My name is Catherine, and I have been a registered nurse for 15 years. I work at St. Michael's Medical Center, a prestigious hospital nestled in the heart of Portland, Oregon, where the Pacific Northwest rain seems to echo the heaviness that lives within those sterile walls. The hospital's architecture is a maze of white corridors, harsh fluorescent lights, and the constant hum of life support machines that never truly rest. Every morning, I arrive at 5 a.m. when the city is still sleeping, when the streets are quiet, and the hospital hasn't yet filled with the chaos that comes with daylight hours. That particular morning in November was cold, colder than usual. My car's windshield was frosted over, and I had to scrape it clean while the November wind cut through my jacket like a blade. I had been working the graveyard shift for 7 consecutive years by that point. Most people thought I was crazy for choosing those hours, but I loved the night shift. There was something about the darkness that made everything feel more manageable, more intimate somehow. During the night, we nurses become the true guardians of our patients. Doctors come and go, but we are there, present, watching, listening to every beep and change in the monitors. The emergency department that night had been relatively quiet until 2 a.m. I had spent the early hours catching up on charting, checking on patients, and having coffee that was probably too strong but necessary to stay alert. The department had perhaps 6 or 7 critical patients, which was manageable for our team. My colleague Susan and I were managing the caseload efficiently, moving between rooms with practiced precision, knowing exactly where everything was, anticipating what each patient might need before they even asked. I remember looking at the clock at 1:58 and thinking about how there were only 4 hours left until my shift ended and I could go home to my apartment, make myself a cup of tea, and watch the sunrise from my kitchen window. I never got to do that. Everything changed at exactly 2 o'clock in the morning when the ambulance bay doors burst open and chaos arrived with a 58-year-old man in acute cardiac distress. Dr. Marcus Sterling had been working at St. Michael's for 12 years, and in the hierarchy of our hospital, he was treated like a king. He was brilliant, undeniably skilled in his field, and had an impressive track record of successful interventions. But his brilliance came with a price, and that price was paid by everyone around him, especially the nursing staff. He had a reputation that preceded him through every corridor of that hospital. Nurses would literally exchange knowing glances when his name appeared on the schedule, and junior doctors learned quickly not to question his methods. Dr. Sterling was a man of about 60, with silver hair, expensive suits that seemed out of place in a hospital setting, and an air of absolute certainty about everything he did. He came from old money, from a prominent Portland family, and there was an unspoken understanding that he was untouchable. The hospital administration turned a blind eye to his behavior because he brought prestige and high-profile patients who could pay premium rates. His arrogance wasn't just personality, it was institutional, protected, and reinforced by the system itself. I had witnessed his behavior countless times. He would snap at nurses for moving equipment, for asking clarifying questions about orders, for daring to suggest alternative approaches. Once, I saw him berate a young nurse named David for 30 seconds straight because the patient's chart wasn't positioned exactly where he expected it to be. David didn't return to work for 3 days. That's the kind of man we were dealing with. The culture around Dr. Sterling was one of fear and silence. Nurses learned not to speak up, not to question, not to offer their observations unless explicitly asked. And even then, the answers had to be delivered with extreme caution, presented as mere facts and never as suggestions. I had never had a direct confrontation with him, but I had certainly felt the sting of his dismissive attitude. He barely acknowledged nurses as fellow professionals. We were, in his eyes, mere technicians there to execute his orders without commentary or independent thought. That night, I had no idea how that dynamic was about to change. Everything. What do you think about Dr. Sterling's behavior so far? Have you encountered people like him in your workplace? Leave your comment below. The paramedics wheeled in a man named Robert Chen, 58 years old, who had collapsed at his home around 1:45 in the morning. His wife had called 911 immediately, and they had started CPR while waiting for the ambulance. Robert's wife, Diana, was in absolute shock, standing in the waiting room with her daughter while we rushed Robert into the resuscitation bay. His face was pale, his breathing was labored, and his vital signs were all over the place. Blood pressure dropping, heart rate erratic, oxygen saturation struggling to stay above 85%. We got him on the monitors immediately. Susan and I worked in perfect synchronization, stripping him of his wet clothes from the rain outside, getting him into a hospital gown, inserting 2 large-bore IVs, drawing blood for labs, getting him connected to every possible monitoring device we had available. The EKG told us immediately that Robert was having a massive cardiac event. The patterns on the screen showed the kind of arrhythmia that means minutes matter, seconds matter, every single decision matters. I called for Dr. Sterling specifically because, despite his personality, he was genuinely skilled in cardiac emergencies. When there's a life hanging in the balance, you don't have the luxury of choosing someone just because they're nice. You choose the best, and Dr. Sterling was unquestionably the best cardiologist we had available at that hour. He arrived within minutes, still putting on his white coat as he walked through the door, immediately taking command of the situation. Robert's family had been told to wait in the family room. His wife Diana was praying, her hands trembling as she gripped her daughter's hand. I would see them later, and the fear in Diana's eyes would haunt me. She had watched her husband collapse, had performed CPR on him, and now she could do nothing but wait and hope that we could bring him back. Robert was sedated and intubated now, his breathing controlled by the ventilator, his heart monitored by 5 different machines simultaneously. We had roughly a window of time to figure out what was happening and how to save his life. I am genuinely grateful that you are still with me on this journey. The best part of this story is still to come, and I promise you it will be worth every second you invest in watching. What are your thoughts so far on Robert's situation? Do you believe everything will work out for him? Please leave your comments below so I can read what you think. In the world of cardiac emergencies, there are protocols that have been developed over decades of research and experience. These are not suggestions. They are evidence-based guidelines that have been tested in thousands of situations. Every hospital has these protocols posted on walls, in textbooks, and in the training programs that all nursing staff must complete. As a nurse with 15 years of experience, I knew these protocols as well as I knew my own name. Better, perhaps. I had studied them, taught them to newer nurses, and applied them in countless emergencies. The thing about protocols is that they exist to protect patients and to ensure consistency of care. They are a form of collective wisdom, developed by the smartest minds in medicine and refined through countless real-world applications. When Dr. Sterling began his initial assessment of Robert Chen, he was technically following the protocol. He ordered the appropriate tests, he was positioned correctly, and his initial medications were spot on. This is why doctors like him are able to maintain their reputations despite their terrible behavior. They do know their job exceptionally well. However, protocols are also living documents that require constant observation and adjustment based on individual patient responses. That's where the true art of medicine comes in. That's where experience, attention to detail, and genuine caring for the patient become essential. That's also where nurses become invaluable. We see things that machines don't immediately capture. We notice subtle changes in skin color, in the patient's response to stimuli, in the patterns of their vital signs. We spend more time with patients than any doctor does. We are there between the doctor's visits, watching, documenting, observing. I had been a nurse long enough to understand something crucial. Protocols provide the framework, but human observation provides the depth. In that moment with Robert Chen, I was watching everything. I was monitoring his chest rise and fall with the ventilator. I was tracking the patterns on his cardiac monitor. I was checking his perfusion, his color, his pupils. I was doing what nurses do best, which is maintaining a comprehensive understanding of the patient's status while also handling the technical aspects of care. Dr. Sterling had made his first set of interventions, and they appeared to be working initially. Robert's blood pressure stabilized slightly, his heart rate became more regular, and we all felt that first glimmer of hope that we might be able to pull him through this. But I was watching something else, something that was bothering me increasingly as the minutes passed. The pattern was too regular, too uniform. It didn't feel right. It didn't match what I would expect to see, given Robert's initial presentation and the medications being administered. Around 3:30 in the morning, as the hospital continued its quiet rhythm and most of Portland slept, I noticed something. It was subtle, almost imperceptible to the untrained eye, but I felt it like a whisper in my bones. Robert's QT interval on the cardiac monitor was lengthening. For those not familiar with cardiac monitoring, the QT interval is a measurement of the time it takes for the heart to electrically charge and discharge between beats. A prolonged QT interval can be dangerous, potentially predisposing a patient to deadly arrhythmias. This was a known possible side effect of one of the medications Dr. Sterling had administered. I had mentioned it quietly to Susan, my colleague, around 3:20. She looked at the monitor and nodded slowly. Susan has been a nurse for 18 years, and she has excellent instincts. She knew what I was seeing. We exchanged a look that communicated everything, without words. This could be a problem. We needed to alert Dr. Sterling, but we also needed to be careful about how we did that because of his temperament. I waited for Dr. Sterling to return from the nurse's station, where he had been writing orders. When he came back into Robert's room, I approached him professionally, respectfully, with the data in hand. I said, "Dr. Sterling, I've noticed the QT interval has increased to approximately 480 milliseconds. It might be worth considering an alternative medication combination given Robert's current status." I had phrased it as an observation, not a criticism. I had suggested rather than commanded. I had been respectful, professional, and careful. By every measure of professional communication, I had done exactly what we are trained to do as nurses. We are taught to advocate for our patients, to speak up when we see something concerning, to use our expertise to contribute to the medical team's decision-making process. This is called being a patient advocate, and it's a fundamental ethical principle of nursing. Dr. Sterling turned to me with a look that I will never forget. His eyes narrowed, his jaw tightened, and in that moment, I saw pure, undiluted contempt. His response came not as a question or a discussion, but as a statement, a proclamation, delivered with the force of someone who had never been questioned before and did not intend to start then. "Don't interfere, nurse," he said. And those 4 words were not spoken, they were thrown like weapons across the room. His voice was loud enough that it echoed slightly in the small resuscitation bay. Susan, who had been working at the equipment stations, immediately went very still. The paramedic who was standing near the door actually looked at the floor, suddenly very interested in his shoes. The respiratory therapist, Miguel, made himself very small in the corner. What Dr. Sterling had done was not just reject my observation, he had publicly humiliated me in front of the entire team. More than that, he had made it clear that my 15 years of experience, my education, my observations, and my concern for the patient were worthless. In a single sentence, he had established a hierarchy that was about domination rather than about patient care. He had made it known that this was his domain, his patient, and that my role was to follow orders without question, without thought, without contributing my expertise. I felt my face flush. I could feel the heat rising from my neck to my cheeks. I was simultaneously angry and humiliated and, if I'm being honest, scared. I was scared because I knew I had been right about the QT interval. I was scared because I could see the potential consequences. I was scared because I was being silenced for speaking up about a genuine medical concern. I was scared because the hospital system had made it clear that hierarchy trumped patient safety in this environment. The response should have been different. Dr. Sterling should have said, "Thank you, I'll monitor that." Or, "You're right, let me review the medication options." Or he could have explained his reasoning. "I'm aware of the QT prolongation, but in this case, the benefits outweigh the risks because of XYZ reason." Any of those responses would have been professional, collegial, and appropriate. Instead, he chose humiliation. I stepped back. I said nothing. I continued to monitor the patient, but now I was monitoring with the knowledge that my voice had been shut down, that my expertise had been dismissed, that I was expected to be compliant and silent. Susan wouldn't make eye contact with me. Miguel was still very interested in that spot on the floor, and Robert Chen was lying on that bed, unaware that the person responsible for his moment-to-moment care had just been told not to interfere. I watched the monitor. I watched Dr. Sterling's face. I watched my own hands as they moved through the necessary tasks of patient care, and I waited. I waited because something inside me, something that comes from years of experience and patient observation, knew that this story was not over. This was not the end of this confrontation. This was just the beginning. At 3:47 in the morning, exactly 17 minutes after Dr. Sterling's harsh dismissal, the monitor began to alarm. It wasn't the typical alarm of a patient moving or equipment shifting. It was the alarm that every cardiac nurse fears. The alarm that sounds like death announcing its presence. Robert Chen's heart had converted into ventricular fibrillation. His heart was no longer beating in any organized way. It was quivering uselessly, unable to pump blood to his brain or his vital organs. In that instant, everything changed. The casual demeanor we had all settled into evaporated. This was now a full resuscitation scenario. Dr. Sterling immediately called out the orders. "Defibrillate at 360 joules. Charge," he commanded. We were moving again. The entire team activated in perfect synchronization, born of countless drills and actual emergencies. I was preparing the medication. Susan was operating the defibrillation equipment. Miguel was managing the airway, and everyone was focused on one singular goal: bringing Robert Chen back. The first defibrillation didn't work. We continued chest compressions, continued medications, continued the cycle of interventions. The second defibrillation achieved a brief rhythm, but it was chaotic, disorganized. Another round of medications, more compressions, more intensity. The third defibrillation finally converted him back to a perfusing rhythm. We all exhaled for a moment. Robert's heart was beating again, and the monitor showed a relatively organized pattern. His blood pressure was improving. His oxygen saturation was climbing back up. But here's what's crucial. That prolonged QT interval that I had warned about, that Dr. Sterling had told me not to interfere with, was directly implicated in the development of this life-threatening arrhythmia. The medical literature on this is clear. The research is definitive. The medication combination that Dr. Sterling had chosen, without adjusting for Robert's individual cardiac characteristics, had contributed directly to what had just happened. I had been right, and Robert Chen had nearly died because my observation had been silenced. As we stabilized Robert again, as we began the process of moving him to the intensive care unit, I noticed something in Dr. Sterling's face. He wasn't looking at me, but I could see that he knew. There was a tightness around his eyes, a tension in his jaw that suggested he understood the implications of what had just occurred. He had made a clinical decision, dismissed my concern, and within minutes, that patient had nearly coded. I want to know where you are watching this from right now. Are you at home, at work, on a break? I would genuinely love to know where you're following this story from. Please leave a comment telling me your location and your thoughts about what just happened. Did you see this coming? What do you think Dr. Sterling is thinking right now? The next few hours were a blur of intensive care, careful monitoring, and the careful documentation of everything that had occurred. Robert Chen remained sedated in the ICU, his heart monitored constantly, his medications adjusted carefully, his condition hourly improving. Diana, his wife, was finally allowed to see him around 6 in the morning, and the weight of those hours of uncertainty lifted somewhat from her face when she saw that he was stable. But for me, the real crisis was just beginning. I understood what had to happen next, and I understood exactly what it would cost. The hospital had protocols for reporting adverse events, for documenting near-miss situations, for ensuring that patient safety incidents were reviewed and learned from. These protocols existed for a reason: to prevent future deaths, to improve care, to ensure that when someone did something wrong, the system could catch it and correct it. I knew I had to file an incident report. I had to document what I had observed, what I had communicated to Dr. Sterling, and what had occurred afterward. I had to be factual, professional, and clear. I also knew what would happen when I did this. Dr. Sterling would see that report. The hospital administration would see it. It would be an official record that I had warned about this medication combination, that I had been dismissed, and that a patient had subsequently developed a dangerous arrhythmia. In theory, this should be a simple matter of patient safety. In theory, the hospital should review this, should recognize that I had done exactly what I was supposed to do, and should address Dr. Sterling's behavior and clinical decision-making. But this is not how these situations typically play out in the real world. What typically happens is far more complicated, far more political, far more damaging. I sat in the break room during my lunch break and stared at the blank incident report form on my lap. Susan came and sat with me without asking. She knew what I was thinking about. She had been in the profession long enough to understand the stakes. Filing this report meant making an official accusation against one of the hospital's most valuable physicians. It meant potentially putting my own job at risk. Doctors have legal teams. Doctors have powerful allies. Doctors have the institutional weight of the medical hierarchy behind them. Nurses, we have our ethics, our professional standards, and our conscience, but we do not have the same institutional power. We can be reassigned to undesirable shifts. We can be given the most difficult patients. We can find ourselves on the receiving end of a hostile work environment. We can be pushed out. I had seen it happen to other nurses who had spoken up about physician behavior. Susan said, "To me, Catherine, you did the right thing in the room. Now you have to do the right thing again. That's who you are." She squeezed my hand and went back to her lunch. I looked at the blank incident report, and I picked up my pen. My hand was shaking as I began to write. I filed the incident report. I documented everything accurately, objectively, and professionally. I described my observation about the QT interval, my communication to Dr. Sterling, his response, and the subsequent cardiac event. I did not include personal commentary. I did not exaggerate. I simply stated the facts as they had occurred. Then I submitted it officially to the hospital's patient safety department. Within 24 hours, the consequences began. Dr. Sterling filed a formal complaint against me, alleging that I had interfered with his treatment of a patient, that I had overstepped my scope of practice, and that I had displayed an insubordinate attitude. The hospital administration, caught between a cardiologist with significant prestige and a nurse with moral conviction, began an investigation. They reviewed the medical records. They spoke to me, to Susan, to Miguel, to the respiratory therapist. They looked at the cardiac monitor tracings, the medication orders, the timeline of events. What happened next surprised me. The hospital's quality improvement team, after reviewing all the evidence, determined that while my communication could have been phrased differently, my clinical observation had been valid. They further determined that the medication combination had indeed contributed to Robert's arrhythmia. They recommended that Dr. Sterling attend additional training on cardiac medication management and patient communication. They also recommended that the hospital implement a structured communication protocol to ensure that all team members felt empowered to speak up about patient safety concerns. Dr. Sterling was not happy. There were attempts to pressure me to recant my statements. There were suggestions that I might be more comfortable working at a different hospital, but something had shifted in the institutional response. The hospital, after reviewing the evidence, recognized that patient safety had to come before physician ego, and they also recognized that I had been right. Robert Chen survived. His wife Diana later wrote a letter to the hospital expressing her gratitude to the entire team that had saved her husband's life. She specifically mentioned that she had overheard conversations about communication and cardiac care, and she was thankful that everyone was working together to ensure his safety. She had no idea about the conflict that had occurred, about the sacrifice I had made in speaking up, about the personal cost of advocating for her husband's care. But her letter was there, a record that my actions had mattered. I made a choice that night in the break room. I chose my patient over my comfort. I chose my professional ethics over institutional politics. I chose truth over silence. And while there were consequences, and while my relationship with Dr. Sterling became permanently damaged, and while I had to navigate a more hostile work environment for a while, I could live with myself. More importantly, Robert Chen could live. That incident happened 3 years ago, and I'm still working at St. Michael's Medical Center. Things have changed, both in the hospital and within myself. Dr. Sterling eventually retired, early, about 18 months after the incident. Whether that was entirely connected to the investigation, I cannot say, but I suspect my incident report contributed to a larger pattern of accountability that became harder to ignore. The hospital did implement the structured communication protocol I mentioned. They created what they call the SBAR system, which stands for Situation, Background, Assessment, and Recommendation. It's a standardized way for any team member to communicate concerns about patient safety, and it's specifically designed to ensure that medical professionals listen and respond to observations rather than dismissing them based on hierarchy. It's not perfect, but it's better. I have worked with other cardiologists since then, and I have spoken up on other occasions when I observed something concerning. Some have responded well, appreciating the additional set of eyes and experience that I bring. Others have been dismissive, but never with the same intensity of humiliation that Dr. Sterling employed. The culture in hospitals is changing, slowly, toward recognizing that patient safety is a team effort. The scars from that experience are still there. I still feel a moment of hesitation sometimes before speaking up, a moment where I remember what it felt like to be told publicly not to interfere. But I speak up anyway, because the alternative is impossible to live with. That hesitation is the scar tissue that reminds me of what's at stake. It reminds me that patient safety is worth the discomfort. It reminds me that my voice matters, regardless of how it's received. Robert Chen comes to our hospital sometimes for follow-up cardiac appointments, and I see him occasionally. He's healthy now, living with his wife Diana, continuing his life. He has no idea that I was willing to risk my career to ensure he received safe care. He simply knows that he survived a cardiac emergency because the hospital staff did their jobs well, and that's enough. I tell this story not for glory or recognition, but because there are nurses listening to this right now who are facing similar situations. There are healthcare workers who are witnessing things that concern them, but are afraid to speak up. There are professionals who are being silenced by the systems and hierarchies that exist in their workplaces. I want to tell you that your voice matters, your observations matter, your courage matters. Yes, there are consequences to speaking up sometimes. Yes, it can be difficult and frightening. Yes, you might face professional challenges and personal stress, but the alternative, the choice to stay silent when you know something is wrong, is the choice to become complicit in a system that prioritizes hierarchy over patient safety. And that's a choice I could never make. 15 years before this incident, I chose to become a nurse because I wanted to help people. That choice was tested on the night that Dr. Sterling told me not to interfere, and I made the decision to honor the reason I had chosen this profession. Every day since, I continue to make that choice. That is what it means to be a nurse, truly, at the deepest level. That is the profession I am proud to be part of. Thank you for listening to my story, for staying with me through these 10 chapters. What did you think about the outcome? Did Catherine make the right choice? How would you have handled the situation differently? Please leave your comments below, as I genuinely read and appreciate every single one. Subscribe to this channel so you don't miss the next story of a healthcare professional facing impossible choices. And please watch the next recommended video, where another nurse shares their experience with institutional corruption and how they fought back. Your support means everything to those of us who have chosen to tell our truth.